move on to the last talk of the session, given by Simon Kennon on balloon aortic valvotomy, useful tool or waste of time. I'm looking forward to this. I've changed my mind over the last few years.
Right. Thank you for asking me to come and talk about balloon aortic valvuloplasty. So here we are, 4:15 on a Friday afternoon, just 2 hours on balloon aortic valvuloplasty to go. Okay, so I'll go through 3 case studies. I'll then go through the literature on outcomes of balloon aortic valvuloplasty, discuss the relative merits of balloon aortic valvuloplasty and TAVI, and then go through what I think are the current indications for balloon aortic valvuloplasty, and that is a purely personal view. Most cardiologists have a different view, and that view is changing as TAVI technology changes and gets cheaper. So case study 1, 86-year-old man who I'd been following for a while actually, and then the last couple of times I've seen him, he's starting to get a bit demented. But I was still able to have a reasonable discussion with him and his son. Physically robust, no concern about him getting through a TAVI. His son reported increased breathlessness. He didn't really remember any symptoms, but he certainly had severe aortic stenosis with good left ventricular function. Both the patient and the son were keen on intervention. He had an aortic valve annular diameter of 23. So generally speaking, for someone of that age, I'd be thinking about TAVI, but the guidelines say TAVI not recommended if comorbidities preclude an improvement in quality of life. And certainly, I don't think for him it would have improved his quality of life because he couldn't remember any symptoms. So I decided, really because he and his son were keen on intervention, to proceed with the balloon valvuloplasty. And I'll just take you through the procedure so you can understand what it involves. So we're meticulous with vascular access to avoid vascular complications. So we start off with a 4 French sheath inserted under ultrasound guidance. Then we put in 2 proglides. I'll show you a slide of a proglide shortly. And then we upsize to an 8 French sheath. He had a permanent pacemaker in already, so there's no need for a temporary wire to be put in. So we put in a JR4 catheter, cross the valve with a soft, straight-tipped wire, push the JR4 through the valve over the wire, take out the wire, put in an exchange length wire, take out the JR4, put in a pigtail catheter into the left ventricle, and then exchange in a super stiff safari wire. So that's a stiff wire which is able to guide the balloon round the aorta and has a pre-shaped curve which is protective of the left ventricle. And as you can see, it's sitting very nicely there in the left ventricular apex. And then under rapid pacing at about 180 beats per minute to drop the blood pressure to 50 or 60 millimeters of mercury, the balloon is inflated. In his case, a 22 millimeter balloon because he had a 23 millimeter average diameter annulus, inflated to nominal volume. And generally, you're aiming to reduce the gradient by 50% or by 50 millimeters of mercury, depending on what the initial gradient is. Usually, you're aiming for a 50% reduction in the gradient assessed at catheterization. So with this chap, single dilatation, pre-procedure gradient on the left, 50 to 55 millimeters of mercury, post-procedure gradient, 15 to 20 millimeters of mercury. So then we put in a proglide device. You can see that on the left bottom corner, and usually that is the wound that you're left with after a balloon aortic valvuloplasty. So this chap had a 20-minute procedure, 10 mils of contrast, and an overnight stay. And in fact, if he'd been done first thing in the morning, he could have gone home the same day. And the plan for him is just ongoing surveillance. And if his dementia progresses and I see him again, then presumably I'll just be saying, okay, there's no further management. But if there is a transformation, then we will consider some form of aortic valve intervention in the future if he were to restenose, and whether that would be a TAVI or a repeat balloon valvuloplasty will depend on how he does. Second patient, 89-year-old lady with severe COPD, progressive increase in dyspnea, which I thought was due to the aortic stenosis, not due to the COPD, good left ventricular function. She had a TAVI protocol CT with a view to being considered for a TAVI, and that demonstrated, not surprisingly perhaps, that she had peripheral vascular disease, and that we would not be able to do a transfemoral or a transsubclavian TAVI. And really, therefore, the only options was either a transapical TAVI or a balloon aortic valvuloplasty. And although I thought her symptoms were due to aortic stenosis, obviously one cannot be sure of that, and also one can't be sure about the benefit she's going to derive from any aortic valve intervention, because we know she's still going to have COPD at the end. So I decided, let's go for a balloon aortic valvuloplasty. Average annular diameter 25 millimeters mercury. So again, the same meticulous care with vascular access. You can see here why she couldn't undergo a TAVI. There's quite severe peripheral vascular disease there. She didn't have a pacemaker in, so she has a temporary wire put in. On this occasion, we used an Amplatz left 1 catheter to cross the valve. Usually, if you've got a horizontal route and a vertical valve, you're more likely to use an AL1. And if you've got a vertical route and a horizontal valve, you're most likely to be able to get across with a Judkins catheter. In this case, Amplatz left 1, straight-tipped wire, temporary wire in place. And you can see how tight this valve was. And again, a single dilatation with in fact, I think it was a 22 millimeter balloon. And gradient pre-procedure 40 to 45, gradient post-procedure was 20, so we've achieved the 50 millimeters of mercury, 50% reduction. And so she is for surveillance now. And if she has good benefit from the balloon aortic valvuloplasty and then has symptomatic restenosis, we can consider intervention again. And conceivably, one could consider a TAVI as the next intervention with a vascular surgeon or a vascular radiologist, the interventional radiologist there, to sort out the iliacs and femorals on the way up. You could say, well, why didn't you do that first time? Well, I think to do a vascular intervention and then a cardiac intervention in the same sitting for a patient when you're not sure about the benefit is quite a big ask. So I think this is a good compromise. Okay, case study 3. This is an 89-year-old lady, frail, 38 kilograms, but still independent, still doing her own shopping. Recent increase in breathlessness. She's now very breathless on minimal exertion. She's got severe aortic stenosis and poor LV function, so the left ventricular function has just gone off. On transthoracic echo, a small aortic valve annulus, 17.5 millimeters. She was very keen on intervention. I thought she was robust enough to withstand a TAVI and would be a good case for TAVI. My concern with her, so she's increasing symptoms, impaired LV function, my concern was that she was just going to drop down dead, or her left ventricle was going to fall apart completely before we could do anything. So I decided to get her in for both the balloon aortic valvuloplasty and to complete all the investigations required for a TAVI. So we got her in, and in fact she had a heavily calcified valve, which you'll see in a minute, and I was a little scared that on dilatation the valve might fall apart. So we just took the shots to demonstrate that the iliacs were big enough to take a TAVI if we felt that was required after the balloon aortic valvuloplasty. You can see the arteries are calcified but with reasonable diameter. We did a diagnostic angiogram as well, which demonstrated moderate mid-LAD disease, but nothing that we would want to treat prior to a TAVI. We then had to put in a temporary wire. This is just, we had to take a picture because it was very difficult to get the temporary wire up. And that's often the case with these patients. They're elderly, everything is tortuous and calcified, so each step requires a lot of patience, care and attention. We got the temporary wire up, So we went for the JR4 with the straight tip, that didn't work. So we went for the AL1 with a straight tip, that didn't work. Eventually got across with a Terumo wire, because it was such a tight stenosis, so a slippery wire crossed in the end. And this is an 18mm balloon. This is the smallest balloon we've got. You may remember on transthoracic echo, the annular diameter was 17.8. So we certainly didn't want to be going any bigger than 18, although in reality the transthoracic tends to underestimate annular diameter. Anyway, she's a little lady, we didn't want to go any bigger. One inflation produced some effect, not enough, we repeated it, and at that stage the pre-procedure gradient of 50 to 55 millimetres of mercury had fallen to 30 to 35. So we hadn't achieved our 50% target, but we decided to stop at the time. And in fact, this was last week. The echo post-procedure demonstrated there had been an improvement in left ventricular function. So it had released a degree of pressure. Before, the left ventricular function had been sort of 25 to 30%. It was up to 40, 45% afterwards. So she had a TAVI CT, and she'll be coming, but she's got to go through the MDT next week and hopefully be coming back for a TAVI a week or so later. Okay, so you can ask questions. Do you want to ask questions about them now or at the end? Shall I plough on? Well, plough on. Okay, all right. So, data. There's a lot of registries out there looking at the outcomes following balloon aortic valvuloplasty, looking at the hemodynamics, and these are both pre and post the onset of TAVI, or prior to and during the TAVI era. And if we exclude the first one, which suggests a reduction in the aortic valve gradient on balloon valvuloplasty of 81 millimetres of mercury, which well, almost unbelievable. If we look at the average gradient reduction is 30 millimetres of mercury with a range of 21 to 50 millimetres of mercury, and the average increase in valve area is 0.35 centimetres squared with a range of 0.19 to 0.59, 0.2 to 0.6. So, of course, if you think about the study with where it was 50 millimetres of mercury, then maybe you'd get a reduction in the gradient, say 30 to 70. That would be the spread of their patients. But of course, in the study, whether the average reduction was 21, some people were getting a reduction in gradient of 10, and other people 30 or 40. So an important point here, and an important limitation of perhaps the most important limitation of balloon aortic valvuloplasty, is that the outcome is variable and unpredictable. I don't really know a way of predicting which patient is going to do well. Sometimes you do a single inflation and the gradient is completely dissipated. So gradient 55 gone to 5, and you know you've got a good result. Other patients, that last patient, you haven't got such a good result in terms of the gradient, albeit she seemed to have had a good echocardiographic result in terms of left ventricular function. But I don't know how to predict that. In addition to that, there is clinical restenosis, so a return of symptomatic restenosis in 50% of patients by 6 months. So those are big downsides to a procedure. What else? Well, complications, again, pre and post TAVI, before the TAVI era, during the TAVI era. And so we've got a stroke rate of about 1.5%. I think in terms of sort of life-altering or life-ruining strokes, I think it'd be much less than that, but still maybe 0.5%. Severe aortic regurgitation, 1.5%. Surprisingly uncommon, actually, to have torrential aortic regurgitation. Myocardial infarction, 1%. Tamponade, 1%. Vascular complications, 11.5%. I think actually tamponade and vascular complications, the incidence of those is lower now because of the experience that people have got during TAVI. So the care with getting access under ultrasound guidance, putting the proglides in, vascular closed devices, and the tamponades have been reduced by using the pre-shaped wires and inserting them via the pigtail catheter. But nonetheless, there's a complication rate, and of course the ultimate complication is death. Again, some further studies looking at the incidence of in-hospital mortality, and you can see range of 2.4% to about 10%, with an average of 5%. I think that's a reasonable number to quote people who are having a balloon aortic valvuloplasty. I usually quote a mortality of 5%. Okay, so what are the possible indications for balloon aortic valvuloplasty? So, palliation, people who've got symptoms, you don't think they're fit for or will benefit from a TAVI, aortic valve replacement. So palliation just to reduce their symptoms for whatever period of time. Cardiogenic shock, people who come in with cardiogenic shock due to aortic stenosis, so a balloon aortic valvuloplasty to relieve the aortic stenosis, get them out of trouble with a view to definitive intervention later, which is a sort of bridge to AVR and TAVI, but bridge to AVR and TAVI is more commonly used to refer to people who have sort of lesser degrees of hemodynamic instability, perhaps have come in with heart failure that has settled, or have had a syncopal episode, or people who are coming to centres where they don't think they're going to be able to sort out the intervention quickly enough for the degree of aortic stenosis. Then there are people where the source of symptoms is unclear, so like the lady with COPD, someone who's got significant aortic stenosis, but one doesn't know if they're symptomatic, don't know if they're going to benefit, so balloon aortic valvuloplasty can be used for that, and to facilitate non-cardiac surgery, as we've said. So there are papers looking at mortality of BAV according to the reasons for the intervention, but in fact, these papers are so different and so heterogeneous. In fact, this data is almost useless. What do the guidelines say about balloon aortic valvuloplasty? Well, the American guidelines say we recommend balloon aortic valvuloplasty as a bridge to definitive treatment, but we don't think it should be used for non-cardiac surgery, to facilitate non-cardiac surgery, and we don't think it should be used as a palliative procedure. And they talk quite a lot about balloon aortic valvuloplasty, but mainly to say, actually, there's no real evidence here to support their use. And I think that's why they say they recommend it only for the use as a bridge to definitive intervention. European guidelines are a bit different. So they agree with bridge to therapy for hemodynamically unstable people, but not generally. So I guess if they're saying, look, if you just don't think you can fit the treatment in quickly enough, well, you need to sort that out rather than giving them an additional procedure. They do agree with it for urgent non-cardiac surgery, and they do agree with it for a palliative procedure. So, what are we doing in the UK in terms of numbers of balloon aortic valvuloplasty? Well, this isn't all the balloon aortic valvuloplasty that's going on. This is a look at the number of patients who undergo TAVI who've previously undergone a balloon aortic valvuloplasty, which I would imagine is probably representative of the overall figures. And as you can see, halcyon days of TAVI was back in 2011. As TAVI took off, I guess balloon aortic valvuloplasty became more common, and now it's just starting to dip off with a significant drop between 2014 and 2015. Why is that? Well, I think there's a number of reasons. So I think partly it is because we're just getting a lot better at TAVI, and TAVI's getting a lot better. So why are we getting a lot better at TAVI? Well, we're doing a lot more of it. This is the NICOR data from 2014. As you can see, Leeds were then doing the largest number in the country at 140, and of course this is just me showing off. So last year, or the last financial year, here at Barts, we did almost 250 patients. We'll do over 300 patients this calendar year, and all the other centres in the UK are ramping up as well. So we're just doing a lot more TAVI, we've got a lot more capacity for TAVI, and we're getting a lot better at it. In addition, TAVI's getting a lot easier. So when we started TAVI, we were using 22 to 24 French sheaths. So you needed femoral arteries that were 8 to 9 millimetres in diameter. Now you need well, you need 5.5 millimetres for a sapien valve, and if it's not too calcified, you can squeeze it in under that. So that is a big difference in terms of the invasiveness of a procedure. How long does TAVI take? Well, when we started, it was taking 2 hours, 2.5 hours. Now everyone's moved over to local anaesthetic, everyone's a lot more experienced, and I would tell most patients that TAVI is going to take 90 minutes, so a significant reduction. And less than that if it's straightforward. If they've got a permanent system in, you don't have to put a temporary wire in, they've got nice femoral arteries, you can be well under an hour for a procedure. Length of stay is coming down. This is the Vancouver program. They started very early on, and they now have a low-risk protocol where people go home the next day. What are we doing at Barts? Well, you can see, bottom left-hand corner, the median length of stay post-TAVI is now, the median is less than 3 days. So that is a major change if you think 7 years ago, 24 French sheath, procedure lasting 2 hours, in hospital for a week. And now we're talking in hospital for a couple of days. Procedure takes half an hour, if you're lucky, and the sheath size is significantly reduced, no surgical cut down. That's a major change. In addition, of course, the mortality from TAVI is significantly less than it was 5-10 years ago, down at 3.7. That's the 2014 figures. So, looking at all that data, you could say, okay, indications for BAV. Palliation, futile, why would you bother? Cardiogenic shock, why don't you just do a TAVI? Diagnostic, well, it's quite a small procedure now, why don't you just do a TAVI? Facilitating non-cardiac surgery, why don't you do a TAVI? Bridge to AVR or TAVI, why don't you just get on and do it? So the answer to all of these questions could now be, why don't you just do a TAVI or aortic valve replacement? I'm not dismissing aortic valve replacement, but most of the people who are being considered for balloon aortic valvuloplasty are generally, mostly are not in that sort of ballpark. But I think that's slightly unfair on balloon aortic valvuloplasty, because we're talking about, on the right-hand side, Sapien 3, the latest valve we've got, and the lowest intermediate risk patients, 1.1% mortality. But in fact, most of the balloon aortic valvuloplasty type patients are not going to have that mortality. They're not going to have the 1.1% mortality with TAVI. They're going to be more up the other end. So that's partner 1, cohort B, the inoperable patients who are having mortalities, in hospital mortalities, or 30-day mortalities of 6.3%. And that's consistent with what we've found here. So our elective mortality for TAVI is 0.6%, but our non-elective mortality is approaching 10%. That's a significant difference. And the length of stay, in addition, elective 4.4, this is a different cohort, elective 4.4, and non-elective length of stay, 7 days. So there's significantly increased length of stay. Finally, going back to the partner cohort B data, so the treated arm, so the medically treated arm, this is people with severe aortic stenosis who are inoperable, could not have aortic valve replacement. They had a 50% one-year mortality. But the treated arm, those who got TAVI, they had a 30% mortality. Should we really be doing these expensive procedures on a cohort of people where 30% of them are going to be dead by the end of the year? Well, my argument would be that we should maybe use balloon aortic valvuloplasty to determine which ones of those patients are going to be alive at the end of the year. I think balloon aortic valvuloplasty can be helpful, and you won't be surprised to think that, to learn that I think balloon aortic valvuloplasty is a useful tool under some circumstances. So if we just summarise the relative merits of balloon aortic valvuloplasty and TAVI, sheath size significantly lower than balloon aortic valvuloplasty, akin to a percutaneous coronary intervention. TAVI much more than it was, but still 14 to 18 French. Duration of the procedure, balloon aortic valvuloplasty, 20 minutes, and same-day discharge or 1 night in hospital. TAVI, 90-minute procedure, not a massively long procedure, but significantly longer. Length of stay, 3 to 5 nights generally. The big things though, aortic valve area, so if we look at the partner 1A data, post-TAVI 1.6 centimetres squared, whereas balloon aortic valvuloplasty, you're hoping for a 0.35 centimetre increase from what will probably be a starting point of 0.5 centimetres. Aortic valve gradient after the procedure, after a TAVI, it's going to be 10 millimetres of mercury, around that. After a balloon aortic valvuloplasty, you're aiming for a 30 millimetre reduction or a 50% reduction. Duration, so balloon aortic valvuloplasty, as I say, 50% restenosis at 6 months. TAVI from the partner 1A data, 0% valve failure at 5 years, although the Danny DeVere data suggests that may change between 5 and 8 in the older iterations of the valve. So, in conclusion, BAV is quick, access, site and size and length of stay similar to angiograms and angioplasty, and balloon aortic valvuloplasty could conceivably be done in non-surgical centres, but TAVI is definitive, predictable and durable. I would say, as I said before, indications for balloon aortic valvuloplasty are personal, vary from cardiologist to cardiologist, and will change as TAVI technology advances. For the moment, my indications for balloon aortic valvuloplasty are palliation. Yes, I think it's a very worthwhile tool. A lot of cardiologists don't, but I think if you've got someone who's come into hospital with swollen ankles, short of breath or minimal exertion, maybe come with pulmonary edema, it's taking a while to settle. Of course, you could look at them and say, we're definitely not going to do a TAVI or aortic valve replacement. You could say, right, off you go home with palliative diuretics, or you could offer them a balloon aortic valvuloplasty. And often it transforms them for the better for, I'm not saying it's going to last forever, but it can give them a reasonable quality of life for several months or more. Cardiogenic shock. Again, we are starting to do TAVIs on these patients because it's so much easier than it was. But I think if they're ventilated and you don't know anything about their cerebral status, then a balloon aortic valvuloplasty is a good choice in such patients. Diagnostic, again, more and more, if we're unsure about whether they're going to benefit because of comorbidities such as COPD, we just tend to do the TAVI. However, if the TAVI is not going to be straightforward, so if they've got severely diseased arteries or perhaps high risk with left ventricular outflow tract calcification or both, then again, that might be a time we'd say, well, okay, let's do a balloon aortic valvuloplasty, and if they have symptomatic restenosis and we're sure there's the potential for them to benefit from a TAVI, then we'd go on and do that later. Facilitate non-cardiac surgery. I think this depends on how much capacity you have for TAVI in your centre. But basically, we would do a balloon aortic valvuloplasty here to facilitate surgery only if it was super urgent. So if you had the time to do an intervention but only a few days, then you might do that. Otherwise, again, we would generally get on and do a TAVI. And I think just going back to the guidelines on non-cardiac surgery, what struck me is that a lot of the people who are going to undergo the operations that the guidelines are talking about would be in their 70s and 80s. And I think just from a sort of human viewpoint, if you're talking about a 75, 80-year-old woman who's waiting for a hip replacement or whatever, you're saying, right, okay, we're going to do an aortic valve replacement operation, then you're going to recover, and then you're going to have a hip replacement. That just seems quite a lot for me. And my view on the guidelines for non-cardiac surgery, as a by the by, is that they should say aortic valve intervention. Here is an indication for aortic valve intervention. We recommend aortic valve intervention in these cases, rather than dictating what intervention that should be, and that should be left to the heart team. Anyway, returning to what I'm supposed to be talking about. So to facilitate non-cardiac surgery, yes, but only if super urgent. Bridge to AVR and TAVI, again, we would really only do balloon aortic valvuloplasty if we didn't think we could do TAVI or aortic valve replacement promptly, and usually these days we can. So that has been a change. 7-8 years ago, there would have just been a yes for all of those, and now there's been a significant change. Thank you very much.
So we're almost at a close, but we have time for a few questions. Anybody want to raise any points? So I'm sceptical about the benefit when we say facilitating non-cardiac surgery, and I would kind of counter and say there is no evidence that it facilitates it at all. And that what you need if you're having non-cardiac surgery, so if you have, I think it's different if you're in heart failure. So if you have somebody who presents in heart failure with tight aortic stenosis who requires urgent surgery, then I think there is a place for valvuloplasty. But I would question otherwise, particularly in people who have not had symptoms or obvious symptoms from the aortic valve prior to their presentation requiring urgent surgery, that balloon valvuloplasty has any role. And what you need is an anaesthetic done by a really good anaesthetist and a quick operation. Yep. And that's probably your lowest risk. And actually by doing the BAV, you don't necessarily reduce the risk, you might actually increase it. So I'm kind of sceptical about that. And we used to do quite a lot, particularly in old ladies who'd fall over and broken their hips, and we've almost abandoned it in that situation. And we have very good results, anecdotally.
I think that's right. I guess if you've got someone with critical aortic stenosis, that's quite difficult. You know, someone who's got a gradient of 100 with impaired LV function.
Yeah, I think that,
but otherwise I agree, either just get a good anaesthetist or treat it definitively.
Yeah. I think I'd say with a good LV, I think is the other thing, is the case. And I think...
I agree with that too.
Yeah.
We've all said the same thing.
Yeah.
Although we got confused in why we got confused.
Yeah.
Because we were half discussing patients with symptoms and half without.
Yeah.
We only do balloon valvotomy for patients with symptomatic scenarios, having the next week cancer surgery, that sort of thing.
And
but we would just check on this in those who are at high risk of coronary disease. It isn't usually it's angioplasty, but that's there.
And I think I do think there's a place for where you're not sure of symptoms, and we don't do TAVI in those people by and large, and we still do valvuloplasty. And again, I'm not quite sure how good it is. We have had, as I'm sure we've had people who've been transformed by valvuloplasty. We've had one or two people who've done valvuloplasty who've never needed a TAVI, and they seem to be immortal as a result of the valvuloplasty. And we've had other people where you get a bit of an improvement in the gradient and they don't really get any better, and they've still got their bad emphysema. And
that is the problem with it. If you get the improvement, you know where you stand. If you don't, it's a bit more difficult.
But I think your message that TAVI is clearly going to be getting cheaper as well as easier, and I think in the future the default is it's going to be the norm. I think to go straight for TAVI. Any other comments? Is there a place for surgery in these people, Norm? No? Nobody else. Right. In which case, thank you to both speakers in our last session. That concludes the scientific session.